Okay, well, I have that it is 6 o'clock Mountain Time, or 8 o'clock Eastern, which means we should get started. Welcome, everyone, to tonight's webinar. I'm going to be talking about using the cone beam CT in relatively routine dental procedures and how it has changed my practice and how it has changed the way that I'm treating my patients. If you have any questions through this presentation, feel free to send a chat. There should be a chat box somewhere towards the bottom of the screen, I believe it is, that will allow you to send a little chat, and that will be monitored by David, and he will either interrupt me as needed or he will save those questions up for when I am done. So let's just get right started. So, you know, when we're thinking about doing our dental procedures and our dental cleanings and stuff, you know, certainly the gold standard is still to do dental radiographs because, you know, we can clean up the teeth, look really nice, they are gorgeous. But if I tell you this dog has a facial swelling, you wouldn't be surprised if you saw this radiograph. So dental radiographs in my practice are still a mainstay, even though I have the cone beam CT and I am using it on every single patient. We do a scan on every patient, and I'll tell you about how that fits into our practice. And then we also are doing a full set of intraoral radiographs. Originally, I thought when I got the cone beam that I was probably going to just stop doing the dental radiographs, and I thought I was going to be just doing the cone beam CT, but I really feel like that I still get good information out of both. There are situations where I think the dental radiographs are useful, and I think there's definitely situations where the cone beam CT is useful. So I'm going to talk a little bit about both of those. But you can see on this intraoral radiograph here that we do have a periapical lesion around the molar, and that wouldn't surprise you that that would cause a facial swelling in this dog, even though the upper fourth premolar looks really nice. But what happens when dental radiographs aren't enough? That's a real frustration for us. So it was for me. This is Sergio. He's a 10-year-old dachshund, and he came into me for, you know, a routine dental procedure as far as dachshunds are concerned. And you can see in his photographs that his upper fourth premolars look pretty normal. They do have little tiny chip fractures on the crowns of those teeth. And on his radiographs, we saw radiographs that looked like this. So I spoke with the owner, and you can see on these radiographs that we have sort of a hint of something that could be a periapical lesion on each of these distal roots, maybe a little hint of something there, but it's not what I would really consider a normal periapical lesion. And I spoke with the owner, and I said, you know, I'm not really sure. These teeth sure don't look like they would be non-vital. And so we re-radiographed him again. This was before I had my cone beam. We re-radiographed him again in about 6 months at his next procedure. They looked exactly the same. No indications of pain, no indications of facial swelling. And so I told the owners, well, we'll recheck them again in 6 months. The radiographs aren't changing. But boy, I'm really bothered by this. I just am not, you know, I'm just not feeling like I can get a good diagnosis. It was bothering me that I might be leaving a lesion behind that I just couldn't tell what was going on. So when I decided to get the cone beam CT, he was one of the first patients that I got on my table because I wanted to know what was going on. So when we get our radiographs, those are our radiographs there up at the top. Here is the slice of the CT of the distal roots, which is where it looks like he has periapical lesions. But you can see here, this is really pretty normal periapical bone. There's not really a periapical lesion in that spot. But what I do notice is how thin this bone is here. So we've got basically no bone, and we've got a huge infraorbital canal right behind it. So what we are seeing that kind of looks like it could be a periapical lesion is probably much more likely to be just that there's just not that much bone in that spot. And this is more of a normal periodontal ligament with a little bit of a chevron. When we look at the cross section here of the mesial roots, so we've got the mesiobuccal roots right here, and then the mesiopalatal root. So mesiobuccal, mesiopalatal, you can see how they're completely overlying the infraorbital canal. So again, there's just absolutely very, very little bone between the roots, the outside, the infraorbital canal. So anything that is looking like a periapical lesion is really not. These are really actually quite normal periodontal ligaments. So I was very happy to be able to tell this owner that this is simply overlap of these roots on the normal structures that are there, but it just in a much more defined fashion that makes it appear to be a lesion when it actually isn't. So I was able to save this dog root canals or extractions on both of these teeth, which I was really quite happy about. Then on the flip side, we've got Cypress. And Cypress is a 15-year-old lab. She was, we were following up on some crowns and some root canal therapies that she had had. We took these radiographs of her maxillary molars. I thought, okay, well, those look pretty okay. And then we look at the cone beam CT and I go, oh my goodness, what is this? Let me see if I can get, I don't know if this, you can see this little box here, but I'm gonna get it out of the way. So on her CT, now we have visible periapical lesions on both of her maxillary molars. These are irregularly shaped areas of bone loss. They're not consistent with just the normal periodontal ligament. And these are true periapical lesions. So we ended up extracting both of these upper maxillary molars, and they were necrotic and non-vital on the inside. So these are teeth that really looked quite normal on the radiographs, and there's just so much bone density here and so much overlap with these roots that you just can't appreciate these periapical lesions. So this is one of those cases where we're finding things on the imaging when we were not expecting it. And unfortunately, I guess unfortunately or fortunately, because I have it, I'm finding this quite commonly. It was actually a little bit of a struggle for me to keep these slides to a minimum today because I had so many cases that were similar to this or in some fashion, something that I really wanted to share. But this seems to be a really common problem for us in this situation. So we have, I'm going to see if I can get my slides to move forward now because they do not want to move forward. Go this way. There it goes. So it appears to be radiographically normal, but has pathology on the CT, the cone beam CT. So we have, I'll try to put this little box here in a different spot. We have Coco here. He is a 3-year-old Siamese cat, and he has pretty severe gingivitis on this upper 4th premolar. And nope, I'm not going to do that. Okay. So radiographically, you can see that he does have bone loss around this root, but not so much in a periapical bone loss fashion. This is actually periodontal disease. And on his oral examination, the periodontal probe drops really quite deeply into the space on the palatal side of the upper 4th premolar. So clinically, I could say, all right, I recognize that this is periodontal disease, and I can see on the radiograph that there is bone loss around the roots, but it's not really super dramatic and not something that I would say is obvious to explain to the owner why there's a problem. But when we look at the cone beam CT of this same tooth, which is over here on this side, you can see that there's bone loss around the root in this area, and we actually have complete perforation into the suborbital space. So when we are probing this tooth, if we are not careful, we could actually poke the bottom of the eyeball with that periodontal probe. So we definitely don't want to do that. And this is a good visualization for the owner to really be able to understand understand why that tooth had to be extracted, as well as a good reminder to the surgeon that is doing it, to the veterinarian that is doing it, that you do not want to slip with your elevator, because this doesn't, this, I can see some bone loss here. That does not look nearly as dramatic as the cone beam CT does, which really gives us a good sense of what kind of complications we could get ourselves into if we're not careful. So we've got periodontal disease and suborbital perforation of the bone around that area. Another good use that I found for the cone beam CT is evaluating absent teeth. So we've got Jackson here. He is a 4-year-old Morkie, and which I assume is a Maltese Yorkie mix. He's pretty darn cute. But he's missing his upper fourth premolar, and we don't know exactly when or who extracted it. But radiographically, you look at it and go, okay, that looks pretty okay. I'm not seeing much. Don't see any draining tracts. I don't see any problems in this area. But we do a cone beam CT on every single patient. And when we do that, we look here and we go, oh my goodness, look at that. We have a root tip, and we have bone loss around that root tip. Here it is on this view. So we have the upper fourth premolar on the other side is over here, and it is still intact. It is this area. This would be one root, this would be another root, and this would be the distal root. So this is going to be the mesiobuccal root most likely. And there is definitely bone loss around it. There is definitely pathology around it that is just absolutely not obvious on the radiographs and not obvious on the visual exam as well. So this is something that we could address having had this. So we use it on, as I said, on every single patient, whether we're expecting real problems or not. And some of them are, a little bit more severe. So this is Shashi Pearl. She is a 13-month-old shepherd mix. She is also missing a tooth. And we might think, okay, so, she's got her canine here. She's got premolars here. She's missing the first premolar. She has some swelling in this area. We think, okay, chances are we're probably going to see a problem. We're going to see a dentigerous cyst. So we've got an impacted tooth here. We've got bone loss. We've got fluid building up in this area. We've treated a lot of these over the years without having a cone beam CT. And we might not think to do it on a impacted tooth. Got another one here. This is Grizz. He's a 1-year-old golden retriever. You can't see the swelling as much on this side, but he is missing his first premolar. Looks a little more dramatic on the radiographs, actually. Looks like a little more bone loss. This second premolar here is actually shifting up and out of the way. But we've done CTs on both of these patients, and so the cone beam CT. And so as we look at these, we've got on Sashi Pearl, we've got very significant bone loss all around this canine. The mandibular cortex and right up to the symphysis is really, really thin. So she is actually much more severe than Grizz is. He definitely has some bone loss and a little bit around the canine. Not quite as bad, and you can see this is actually bilateral for Grizz, being a golden retriever that he is. Not supposed to have that, but he decided to. But now look at this view. So not only is it thin this way, it's thin this way, lots of bone loss. So this is a very, very fragile mandible that really is difficult to appreciate on this radiograph. And again, we're able to talk to the owner in preparation of this for the surgery and tell them about the risks of problems. Might even have some involvement of the incisors up here, which is very difficult to appreciate radiographically. And you can see on Grizz, he definitely has a very thin cortex on the mandible here in this area, but not actually nearly as dramatic as Sashi Pearl. So it really helps with our treatment planning in situations where we wouldn't normally be considering doing a CT. So, we do have our patients that, you might have a CT available to you. And if you do, that's fantastic. Vincent is an 11-year-old male neutered cat. And as you can see, he's had a rough day. And this is the kind of case where traditional CT would probably work just fine. And I have my cone beam CT, so I use it. I actually have access to both, but I use the cone beam CT for this. I'm able to get really nice imaging of his mandibular fracture, his symphyseal separation, and back in the back here, we can see that he's got quite a few mandibular fractures. We can manage that with the treatments that we need to do and be able to get that type of imaging. So this is the kind of thing that, yes, a traditional CT would work great, and you probably would be doing a CT for any type of fractures, but lots of patients that we wouldn't normally be doing CTs on, I'm finding that we are getting really valuable information out of it. For example, Odin, he is a 6-year-old Airedale, and he comes in for a maxillary canine fracture. Radiographically, you can see he's got a little periapical lesion around it, and we go, okay, yep, he's got a fracture, he's got pulp exposure, actually has some wear on this lower canine too, looks like a good candidate for root canal, but let's look at the cone beam CT. Cone beam CT is actually showing a pretty nice canal, and then all of a sudden we've got these diversions down here. So this is the type of situation where this canal is split, and we did still perform the root canal on this tooth. We were able to do that and able to save it, but we need to know that this is going to be a little more difficult to get a good apical cleaning. We're gonna have to get this canal much wider than we think because we've got these deviations at the end. And if I look back at the radiographs, I can make myself believe that I think I can see that there, but honestly, it's not something that we noticed prior to having the CT to be able to see. And you just wouldn't normally think to do a CT on every root canal. But I'm finding actually quite a few situations where I'm very glad that I had it and had that information. This is Charlie. He is another dog that presented for a broken tooth and an expected root canal therapy. When we look at his radiograph, we say, okay, don't see periapical lesions around those teeth. Definitely have a crown fracture. We can see that visibly. We have pulp exposure. Should be a pretty decent candidate for a root canal. But when we look at the slices of the cone beam CT, look at all this internal root resorption that we've got going on here. So instead of having nice, normal, thin canals, we've got these really wide, really irregular canals. We have a lot of internal root resorption on this tooth. So pretty severe damage. And this tooth was actually extracted rather than being able to perform the root canal because of that. So having the cone beam CT in this situation actually changed the plan that I had, even from the dental radiographs and from my oral exam. And I'll tell you a little bit more later on about how often that happens in my practice. So here is JJ. He is presenting for this very severe wear of his teeth. Quite a few teeth are abraded, worn down, pulp exposed, and this maxillary canine in particular, we look at our radiographs and we say, okay, we've got some root end resorption here. So it's not a nice smooth apex, definitely looks irregular. We have a periapical lesion, but overall not too bad of a candidate for a root canal. It should be an option that we could consider. However, when we do our cone beam CT, here is the end of that apex of that canine tooth, and we have a buccal bone perforation here, and we actually have a sinus perforation here. So we do have a periapical lesion, but we have pretty significant damage on this tooth. I elected to extract this tooth. It's possible that you could consider doing root canal therapy on it, but this would be one of those situations where if you choose to do that, you have to be prepared that any of your cleaning agents that you're using to work on the root canal could leak out and could potentially leak out into the sinuses. So, you know, we've all had that, those of us that have done root canals have all heard or read about situations where bleach ends up in the nose, or they have, if you read about doing root canal therapy in humans, there's always horrible pictures of bleach leaching out into the tissues. This would be the kind of situation situation that I would expect that could potentially happen, because we've got that root end resorption and we have perforation into the sinus. So I spoke with the owner about it. I told them that there was a possibility that we could end up with the medications out into the sinuses and potentially have nosebleed or damage. So we elected to extract that tooth. So again, the cone beam CT changed my treatment plan, where I thought that might have been a reasonably good candidate for a root canal. Kind of decided that it was a little higher risk than we were willing to take in that situation. Here's Piper. Piper is a 2-year-old Yorkie, and he presented for a routine, as it is, cleaning. That for a Yorkie, nothing is ever routine. And his referring veterinarian was quite surprised by the periapical lesions on this tooth that looked perfectly normal on the surface. And we can look at that with our dental radiographs and say, oh, yep, we know exactly what that is. Those are dilacerated roots, and those are periapical lesions from that. And that's, you know, pretty standard in the small breed dogs. We've got periapical lesion right here. Got another periapical lesion right here. And but you know, what is this? This is kind of interesting. I wonder what's going on down here. So when we do our cone beam CT in this area, when we do our 3D reconstruction, you can actually see that we have a draining tract out the mandible. So not only do we have these periapical lesions, but we actually have a draining tract. And you can see it on the radiograph here, where we have a draining tract right here and a draining tract right here. That's caused this little bridge of the mandible to be all that's left holding that little section in place. So in our cross-sectional views, you can see the periapical lesion, but this actually communicates straight out the bottom on this side. And then this is looking at a cross-section this way of this tooth, and you can see the draining tract going out through the ventral cortex and going out through the buccal bone. And then this is that a little cross section of that little bridge right there. So we were able to extract this tooth without fracturing the mandible. But again, it gives us much more information so that we can make wise decisions about bone removal, about debridement, and about treatment options, and then preparing the owner for what might or might not happen. That is, you know, you could kind of see it on the radiographs, but this just gives it much more visibility that really helps the owners as well as helping the veterinarian make a better plan. This is a Oreo, which I thought was a really cute name. Is O-R-I-O, and his owners call him Oreo. And he is a 12-year-old border collie mix, and he has this canine tooth. Radiographically doesn't look too exciting, but when we look at our cone beam CT, we can see huge chunks out of the tooth on this buccal bone. So we actually have periodontal disease. So we have buccal bone expansion here. We have periodontal disease, and we have external root resorption that is clear on the cone beam CT, not nearly as clear on the radiographs. And so that is an indication for extraction. That is external root resorption. And on periodontal probing, you can feel kind of rough stuff under the gums, but kind of just feels like calculus under the gums. So this just gives us a lot more information that we weren't expecting. Here's Bo. Bo is a 15-year-old cat. His teeth look pretty happy clinically. Radiographically, we look at them and go, okay, well, the molar looks pretty okay. It looks like the third premolar here has resorbed, so it probably had tooth resorption. Can see a little bit of the bump in the bone here where that tooth had resorbed. This tooth looks kind of funny though, not really sure what's going on with that. Definitely the crown looks really good. Doesn't seem to have the normal tooth resorption here somewhere in the furcational area, but these apices don't really look quite right. Don't have nice periodontal ligaments around them, don't have nice alveolar bone around the ends. So what's going on there? So we look at our cone beam CT and we can see resorption. So now we have some type, and I don't know exactly what happened here. I'm guessing this was internal root resorption that ate away and damaged the roots. So now we have this huge chunk missing out of this mesial root here. And then we've got huge pieces missing out of this one as well. So this tooth was extracted when I'm not sure what I would have done with it on this without having the cone beam to see what I would do as a backup. So it's a version of resorption that was kind of an interesting thing to see. The other thing that I find when I'm using my cone beam CT is I'll actually use the information during the procedure. So rather than just kind of looking at it and making my plan in comparison with the radiographs, sometimes I actually use the information and reference it during our procedure. So you can see in this case, this is Ace. He is a 6-month-old Newfie, and he has retained deciduous teeth. So I think he's got some Chihuahua in him somewhere, but he was like 80 pounds, so probably not very much. But he's got these retained deciduous teeth, and they are, you know, right up against the permanent teeth. The permanent teeth are erupting, so we know we need to remove those baby teeth. Here's our radiographs. So we've got a radiograph showing there's the permanent canine tooth. Here's the deciduous tooth right here. Doesn't really look like there's too much tooth structure to it. Here's the one on the other side. So I've got both mandibles up here, but the maxilla looked pretty similar. So we've got just a little bit of tooth there, and it doesn't really look like there's a whole lot of tooth structure. But let's see if we can play the video. And what we're showing on this video is starting at the rostral end, so starting towards the closer to the nose, to the incisors, and then scrolling our way backwards. So we're actually looking at the CT and we're scrolling distally or scrolling backwards towards the canines. So you can see the permanent canine teeth coming in. Here's the deciduous teeth out there. Look at how much resorption of the edge right there that we have. But then as we get to the tips, now we have intact teeth again. So this is something that I would expect this is going to break. And I'm going to try to see if I can play that video again here. Let's see if it'll make it happen for me. It may not. Oh, nope. I'll go backwards. So anyway, the point that I'm trying to make with this is that that we have the, there we go. So we have the resorption of the baby teeth right up against the permanent teeth, and that is a really fracture point for those deciduous teeth. But there is still root structure behind it, and there's still very intact tooth roots that are past that you cannot appreciate on the dental radiographs. You can't see where those are. And of course, as you look at this, you can also really appreciate the eggshell effect of the permanent tooth, how thin that tooth is in comparison. So being able to be prepared for that baby tooth to break in that spot, or try to prevent it from happening. So making a flap, doing your surgical access a little bit differently so that you know you can get past that fracture point so that you can get the entire tooth out in that situation. That was very useful to have that cone beam CT, and then explaining to the owner why it was took so long to extract those teeth and how difficult it was and how thin and fragile they were. It's much easier to show with the images from the cone beam CT than it is just from the dental radiographs. Here's another situation where I found it really useful. This is Lily. She obviously is a toothless cat. She is 2 years old, and she has gingivostomatitis. And she was, her extractions were performed at some other clinic that I don't know about, but they were convinced that there were no roots left behind. We look at this radiograph and we say, okay, that I don't see anything super obvious that appears to be tooth structure. But when we look at our CT, there is actually a maxillary tooth, and I could see that one on the dental radiographs. But looking at the dental structure here and the way that it appears in the maxilla, now you can see that there's dental structure in this mandible, and there is dental structure in the other mandible as well. So what we are seeing over here that you really can't tell what's happening, there are definite tooth structures in that area. So what we did is we actually took another view and turned the cone beam CT image so that I could see the entire mandible of both sides. So this is basically a cross section right through the mandible, and I can see clearly 3 tooth roots here and 2 tooth roots on this side. So we were able to use the cone beam CT to clearly identify tooth roots that were not nearly as obvious on the radiographs as they were. And that should help this cat. We just did this surgery actually about 2 weeks ago. So I don't have any good results yet on whether her stomatitis is going to resolve with removing those tooth roots, but certainly it wasn't helping things any. One of the things I like about the cone beam CT that you can't do with a traditional CT is you can do an intra-op scan. So not only do we do the scan at the beginning, if I have any questions about the treatment plan that I'm going or the progress that I'm making, I can very easily roll my cone beam CT right up to my treatment table. I don't have to move my patient at all, and I can get another scan. So I did that in this cat because I wanted to be sure that we got all the tooth structure out. She had just a little bit of movement during the scan, so it just looks a tiny bit fuzzier, but you can see very clearly where I've removed bone in order to get to those tooth roots, and that those tooth roots are completely gone. So I was able to do a scan intra-op, get it done quickly, and I could confirm, since I can't really see them on the dental radiographs anyway, I tried taking dental radiographs to make sure that they were gone, but can't see them at the beginning. So how are you going to see if you confirm that they're gone? So having the cone beam CT allowed me to do that. Here's another situation where we actually use this intra-op. This is Cash. He is a 6-month-old Mastiff, and he has a whole bunch of missing maxillary teeth, very large facial swelling. Again, this would probably be a good example where having a traditional CT might be a good approach to this. Certainly the cone beam CT has a little bit of a limitation in soft tissue changes. So for soft tissue masses, I really like the traditional CT better, or in combination with the cone beam CT. But we do the cone beam CT, we see this, we say, okay, this is definitely dental structures here. We're able to open this up, identify that we're working with an odontoma. So we've got dental structures in this area. You can imagine a 6-month-old Mastiff. We've got this big, huge mass, big, huge swelling. It's bloody, it's yucky, there's lots of stuff in there. You're just kind of scooping it out. It's just very, very difficult. This is the scan. So here's our normal side here at the level of the molar. Here's our odontoma on this side. So we've got this nice bone where the bone expanded to accommodate the odontoma, going in through the occlusal surface where the teeth would normally be, opening a window here, trying to scoop all of this stuff out. But you can imagine, we got this big, huge swelling here, this bony swelling, big, huge hole in this poor little dog's head. So we did a scan intra-op before we closed it up to make sure that we got everything. And as we look at the scan, you can see the air in the scan here where we removed all of that tooth structure. But oops, here's another tooth that's completely set in. Here's another tooth right here, and here's another tooth right here that we're further away from our surgery area than we could visualize. So we literally had to go back in and keep looking for those. So having that intra-op scan allowed us to be able to diagnose the fact that we actually thought we'd gotten everything, but really didn't. And we were able to get all of that out and get that dog feeling better and on the path. So this is odontoma intra-op scanning. So adding the cone beam seat to the procedure, the way that we do it in our practice is that we have our patients on their back, and we do our scans immediately after intubation. So we've intubated them, we've hooked up all of our anesthetic monitors, we put them on their back, slide them forward. There's a little carbon fiber plate here that allows their head to overhang the normal table that we're working on. We have them in this V-shaped padded trough to support their back, and warm water circulating blanket, keeping them warm, all of that. So we get them all hooked up, slide them forward, get our scan, and then we can slide the patient back onto the table. Once the scan's complete, the technicians can do their cleaning, they take their dental x-rays while the doctor is evaluating the scan. So if my video works, I'm just gonna show the scan in progress. One of the things that I really like about the cone beam CT is how quick it is. We're able to get a scan in 20 seconds and it reconstructs within about less than a minute. So we're able to get that information very quickly, move the patient back, move on with the rest of the treatment, and it's not taking up a huge amount of time. So here is the video that is showing the scan in progress. You can see my technician, Chrissy, there. She's our anesthetist working on her iPad, monitoring the anesthesia. And this is doing the scans. This is actually taking the cone beam CT scan. And as it completes its full circle, it will be done. And that is all it takes. And you're able to then let it do its reconstruction. We leave the patient in place, allow it to reconstruct, make sure that we're happy with the scan, make sure we're happy with the positioning of it, get everything from the nose to the TMJs, and allows us to get that information. The doctor can look at it while the technicians are doing the rest of whatever dental procedure that is. Incidentally, this is Grizz, that golden retriever with the bilateral dentigerous cysts. So we do find some incidental things as well. This is Django, and he is a 12-year-old cat. Pretty sure this is something in the ear. I don't know what it is. It's asymmetry. It's behind the teeth. So I don't know what to do about it, but I'm able to diagnose it and say, there's something wrong with the ear. You need to go talk to somebody else. And that's what I do with it. I say, yep, I can see an ear problem. I've got asymmetry. There's fluid in this ear and not in this ear. This doesn't probably look quite right either, but I don't know about it. You go talk to somebody else that knows more stuff and get that fixed. But we find incidental findings quite a bit. Ricky is another situation. He presented for treatment of a broken mandibular canine, and on his scan, we actually found a huge amount of fluid density, in his nostril and in his sinus. The owners did not perceive any problems, but you can see he's got nice turbinates on this side and just a completely fluid-filled sinus on this side. And it almost looks like he even has a palatal perforation here. So we were pretty concerned about a neoplastic process, even though he's only an 8-year-old dog. We did end up sending him to an internal medicine specialist so that they could do a rhinoscopy and get some answers. And luckily on rhinoscopy, they decided that this was a nasal adenoma. But they were able to get that information for the owner, didn't even realize that there was a problem. After we saw this, the owner said, yeah, he's been snoring quite a bit, but when he sleeps, but we really didn't think that much of it. We thought that was just kind of normal for him because he's done that for a long time. So they didn't even know there was a problem until we were able to recognize that for them. Here is Sweetie. He is a 5-year-old cat. He was a rescue that the owners had him for 2 or 3 years, didn't really perceive any problems. He was presenting for tooth resorption, as many cats do. And on his scan, he had the unfortunate luck of being shot before the owners got him. So we were able to identify that for her. I elected not to go after that. It looks pretty deep and in a place that I don't really want to mess around. But the owner knows now that that is there and is able to keep track of it and can recognize and pay attention to whether or not he develops any nasal symptoms or any sinus issues. She is able to know that that is there. So in summary, we have had our cone beam CT since July of 2018. And we've done a total of 817 scans. This is as of yesterday. So I did this count yesterday. And as I said, we do it on every single patient. If we did a scan within the last year and we're seeing them again for another procedure, we usually don't repeat it unless there's something that we're tracking or something that we're monitoring, like retained tooth roots, or if we're leaving those for some reason, or probably, you know, Sweetie with his pellet, I'd probably be scanning him every time I have him under anesthesia. But in general, if I don't find anything unusual, we probably do a scan every couple of years. But honestly, we've been keeping statistics on all of these scans. We keep statistics on how often it changes things, how often we add information, and only 18% of our scans added no additional information than the visible exam and the full mouth intraoral radiographs. That means 82% of our scans added something, whether it was more information about how to handle the treatment, like for example, the cat with the periodontal disease that had the suborbital perforation, or it was information that we needed intra-op. There's a hook on the end of the root and we need to know which direction that is. I wanted to show some of those, but I just didn't have enough time. Having the information about where the root canal is a good root canal, is it not a good root canal candidate. 82% of our patients, the cone beam CT added something to what we were doing to make this better for us. And 10% actually entirely changed the clinical plan that we had for that patient. Whether we were going to do a root canal, we ended up extracting, or we were going to extract and we ended up doing a root canal, or like in Cypress, was she had the molar issues, the maxillary molars. Radiographs didn't show anything that was diagnostic, ended up extracting those maxillary molars because of the periapical lesions. So 10% out of those scans completely changed based on the cone beam CT versus just what we had prior to that. And then about 5% had non-dental problems, like those examples that I just showed at the end. Something in the bulla, something in the sinus, maybe something in the TMJ that we weren't expecting. May or may not do anything about those, but it's information that's been useful to the owners, and then they can pursue other treatments if they are interested. And I have Piper in here. He is a 60-year-old miniature poodle. He's pretty darn cute, but the cone beam CT in his situation, the reason that I have him here is because if we had to extract these maxillary fourth premolars, which thank goodness we do not, but if we had to, take a look at where this mesiobuccal root is in relation to the infraorbital canal. That is in the infraorbital canal. So isn't that nice information to have before you start extracting that tooth rather than afterwards? I kind of think so. So that's why I like my cone beam CT. I've been using it and I will continue to do scans on every single dental patient that I have to get the most information and make the most use out of it. So I appreciate your time listening to me. I hope this has been helpful on how you can see that we are using it in our daily dental practice. Please feel free to ask me any questions that you might have, and I'm going to turn the video and the audio back over to David Sarmet from Xoran.
Dr. Bannon, thank you so much. This was a fantastic presentation. You've covered quite a bit of ground, and they were really great examples of the daily use of the cone beam CT practice. There we go.
Let's see if I can get it back to you. There we go.
Oh, thank you, thank you.
Let's see if that's going to work.
There were a couple questions
okay.
regarding your presentation. One of them was your learning curve. As of now, you've described the daily use of the device. However, one of the questions was, in the beginning, you know, your learning curve to sort of put the machine at ease within your practice and your workflow. Can you describe how that took place?
Yeah, so the learning curve for it, I would say, was much faster than I expected. I do have a traditional CT in my building. I share a building with a neurologist. We hadn't used it very much. They actually, one of the reasons that I started looking at getting a cone beam CT was because the traditional CT kept breaking down. So every time I wanted to use it, it wasn't working, which was very frustrating. So I didn't really have a lot of experience with the CT prior to using this, but a little bit of research and using it on every single patient really made a difference to me. The same way that just learning dental radiographs, the more you do full mouth radiographs on every patient, the more quickly you will learn normal from abnormal. I would say, you know, I sent out several scans at the beginning to radiologists to ask for review. I sought help from other people, such as yourself, looking at scans for me and helping me see what I was looking at. But I was self-sufficient within very short weeks. I would say easily within the first month, and only needed occasional assistance and sends off for things that were non-dental related. And that's the only time we send things off now is non-dental cases.
Oh, thank you. So there's actually there was a question that was coming up as you were describing it, which is whether you send those CBCT files for radiologic review. So it seems like now you sort of limit this to those few cases where it's outside of the scope of your daily practice.
Yes. Yeah, if there's a non-dental issue that I am identifying, then I will send those out for radiology review. But any of the, or send them to someone else, like for example, the ear cases, I'll send the CT directly to the dermatologist that we work with and have her review it and speak with the owners about those issues that they have. The sinus ones I send to the internist. So we don't normally even send most of them out to a radiologist anymore at all.
Okay, a couple more questions here as they're coming. The next question is, what CBCT books do you use for reference?
There's one by David Sarmet that I used, and I can't remember what it's called. I'm sure that you can tell me the name of the book that you wrote, though.
Yeah, it's a book on the use of cone beam CT in maxillofacial on the human side. So maybe
yes.
Reviews.
Yes, yeah, that was the main book that I used for reference. And after that, it's just simply practice and learning what you're seeing and what you're looking at.
Another question here, do you charge extra for intra-op and post-op CBCT or consider it part of the original charge?
So for my practice, I've chosen not to charge additionally for that. We priced our cone beam CT not very much above a full mouth x-ray series. And even with that, we have generated several $100,000 in revenue over and above the prices. So I have chosen that if I want to do it because I want to know that all my roots are out or I need that information, I'm not going to charge a second time to do it. That's my personal choice. Everyone, of course, has the right to do as they choose. I don't charge for radiographs either. If I'm taking 10 x-rays to try to find a root tip that I can't find, I don't charge that client for each individual x-ray. They get charged for taking dental radiographs, whether it was 5 x-rays or 50 x-rays. So that's the way that I've handled that in my practice, and I don't charge additionally for any other CTs as I need to.
Well, I'd like to thank you again for taking the time to put this fantastic series of cases together and share with us your experience and your excitement of using the technology. So thank you so much, Dr. Bannon. Thanks for everyone to joined the webinar this evening. This has been recorded. It will be available in the next few days for a review. And I'm sure a lot of people will be interested in going back to your explanations and your description. Thank you so much. Thanks to everybody.
Thank you. Thank you guys very much for all listening to me. I appreciate it.